concern is progressive difficulty swallowing with odynophagia for 10 days. Do you want me to go further?
Oh, I can just wax poetically for a second here and then pass it up to Robbie and then we can go. So odynophagia and so 10 days of odynophagia and dysphagia, correct, Kanu? Did I hear that correctly? Okay, great.
Yeah.
So usually with dysphagia, so let's start there and then I'll ask RG to layer on odynophagia on top of the dysphagia. So when it comes to the dysphagia, couple of things in the beginning that I just like in terms of a schema when I think about, we don't know who this patient is. So in terms of the schema itself, that you want to make sure that, you know, there's no issues with like decreased saliva production that can mimic dysphagia. So that's something to keep in mind in terms of like medication side effects specifically that can cause a dry mouth that can be mistaken for dysphagia. In terms of dysphagia itself, we think about more oropharyngeal and esophageal causes of dysphagia. And Steph Lay has this great blog post on CP Solvers about dysphagia that I highly recommend. It helped me tremendously to think about more whether a patient is coming in with oropharyngeal or esophageal dysphagia. And that's like kind of like the first branch point to think about whether like the initiation of swallow is more issue. Sometimes with this esophageal, people tend to point to their chest as like food getting stuck in their mouth as well. So questions that help distinguish between that is helpful. And the time onset is also important. So thinking about the 10 days, usually like acute dysphagia, we think more about like strokes that can happen, and it usually presents as one of the main causes of oropharyngeal issues, in addition to like, you know, dementia that we see commonly, and like neurodegenerative diseases. So the patient, who the patient is, their age, their background would be very informative. And more of the esophageal causes, then we think about like, you know, with the luminal issues, the muscles, the nerves involved, and also the external compressions are the big categories that I think about. I can wax poetically, but I think it's good to stop there and then ask RG to layer on the odynophagia.
Y'all, did you hear that? This is the first time that Charmaine was brutally honest with you about her own skill set, which is true. She could wax poetically forever. I'll never forget this moment. The queen humility. Finally, the truth comes out.
Not well. I mean, I can wax poetically, but it might not be well, okay. And that's fine.
back to your ways of minimizing your skill set. Sure. Nobody believes you. That was absolutely superb. And the key question is, what does odynophagia help with that? Charmaine just laid out a master schema, right? She's like, these are the entire range of possibilities. And now we have to use a sub word, odynophagia. And for a second there, just think about how we complicate things. This person just saying, ow, it hurts when I swallow. And we are mapping on words that are so incredibly complicated. But basically, odynophagia is, it hurts when I swallow. And what does that do to the word of dysphagia means I am having trouble swallowing. What does the fact that there is pain involved tell us about the nature of the difficulty? And it just means that there's an inflammatory disease process involved. This is not trouble swallowing because my muscles aren't working so well. This is not trouble swallowing because I have a mass in the way. This is trouble swallowing because it hurts me, and the hurt essentially means there's an inflammatory lesion along that pathway that Charmaine articulated. So when somebody says, I'm having a hard time swallowing, it usually for us means that the difficulty is just in moving the bolus of food down to the stomach. And that localizes, as Charmaine eloquently said, to either a muscle issue moving the food or something blocking the food from getting to the right place. But the odynophagia here changes the calculus and prioritizes an inflammatory disease process along that pathway. So the question is, where does inflammation marry with trouble swallowing? You'll be hard pressed to find oral causes of inflammation or oropharyngeal causes of inflammation that cause dysphagia. So odynophagia prioritizes an esophageal disease, though oral candidiasis can be painful and other oral lesions can be painful. But if you hear odynophagia, you're probably moving towards the esophagus as the lesion. And the key questions are the things that you can immediately ponder. Infectious diseases of the esophagus are usually in immunocompromised patients. So that's going to be important to know. Candida, HSV, CMV, most of them occur in immunocompromised patients. This is the one instance where you're looking at the medication list much more closely because pill esophagitis, doxycycline, potassium are much higher up on the list. Only after that will you scrutinize less common causes of inflammatory diseases in the esophagus. But these are, when you hear odynophagia, your reflex should be, what is the immune status of the patient and what's their medication list? And most patients, you'll arrive at a conclusion from that. Some you'll have less common causes, but we'll save those for later. All right,
RG, I have one word to say.
Yeah.
Tunnel.
Oh my gosh, I was gonna do that, but I was like, you know what, let's save these people from the. Yes, Charmaine is referring to our dysphagia episode in which I embarrassed myself by yelling the word tunnel. I won't explain that to you now, but I'm glad it's etched in Charmaine's mind.
All right. So before presenting to us in the emergency department, she was seen at an urgent care. There was a presumed diagnosis of mucositis, and she was started on oral fluconazole and a statin mouthwash. So she took that for 7 days for presumed Candida. She still didn't resolve. And by the time she presented to us, she was very confused, not even able to give us a proper history at that time. And she had completely decreased PO intake, not able to swallow. She was also not able to speak by the time she presented to us. Of note, she does have a past medical history of malignant melanoma, and she is on immunotherapy, pembrolizumab. She received her last infusion about 10 days before presenting to us. Apart from that, I think I would stop there. After that, I want to keep it short, so I'll stop it there.
I'll just share a brief overview of cancer-related complications because that's the dominant history that you've given us. And folks, I think this is actually really important. Your temptation here probably is to immediately jump to individual diagnoses, and that's okay and understandable. But that will come at the cost of having, just like Charmaine shared, a master schema to dysphagia. How can we have a template to approach cancer and its complications? And let me tell you that it ultimately comes down to one of three things. This is a direct issue related to a mass effect of the cancer. Examples would be a mass obstructing the bile duct causing cholangitis. A paraneoplastic effect, so a distant effect like SIADH. And finally, treatment-related complications. So the three complications related to cancer are, is what's up with the mass itself? Is it compressing something? Or is it bursting, causing tumor lysis? Is it causing a distant paraneoplastic effect like paraneoplastic thrombosis, which we associate very commonly with cancer, paraneoplastic encephalitis, SIDH, so on and so forth. And then finally, complications of treatment. And here, whenever you hear the word dysphagia and you have cancer in the background, your reflex should be, is there an anatomical region for this dysphagia? And the problem with that hypothesis is that it's not as well associated with odynophagia because a mass is just sitting there. It shouldn't hurt to swallow. Are there any paraneoplastic consequences? Absolutely. Achalasia can be primary, but also paraneoplastic, but again, shouldn't hurt unless there's a complication. Now, and finally, is there a treatment-related complication? The answer is heck yes. Pembrolizumab can basically cause an itis of anything and is unfortunately associated also with colitis, esophagitis, and mucositis. So we'll have to think about that here. Anything to add, Charmaine, before we get more data?
That was beautiful. Nothing to add.
All righty, Connor, back to you.
All right. So other past medical history for her, she has hypertension, hyperlipidemia. She has autoimmune hypopituitarism, likely from pembrolizumab with hypothyroidism. She is on replacement therapies for both of them. Family history, she has coronary artery disease and lung cancer and father who unfortunately passed away. She is a non-smoker, non-alcoholic, and her allergies only include aspirin. None of her current medications include potassium or doxycycline. I made sure of that. So, and not iron either. So it wasn't that. She has an extensive medication list. So that's why I didn't want to share here, but none of those were there. Vitals, she presented with temperature of 98.0. Her heart rate was in 106. Her blood pressure was slightly soft at 98/60. And she was setting 94% on room air. Generally, she appeared very dehydrated. An oral mucosa exam. She had grade 4 mucositis on exam. She had parched mucosa with sloughing of the mucosal layer. She also had some evidence of whitish plaques over the back of the soft palate, but nothing over the uvula or the tonsils. She also didn't complain of any tenderness along the tonsillar pillars. She did have some dental caries. Apart from that, she didn't have any cervical lymphadenopathy or any axillary lymphadenopathy. Rest of the cardiovascular pulmonary abdominal exam was normal.
Kanu, you're awesome. Can I just ask you, how old is the patient, by the way? I don't think I caught that.
I'm sorry?
How old is the patient?
Oh yeah, 61-year-old.
61. Okay, thank you, thank you. I think just like wrapping the past medical history and thinking a little bit about the exam here. I think just the note about the pituitary gland. I think now with the use of the PD-1 inhibitors, and so they're fabulous drugs in terms of like what allows us to do with treatment of cancers. However, the whole slew of side effects and pituitary, now I think like one of the most common causes of pituitary issues is PD-1 inhibitors, which is kind of mind-blowing compared to like even 10 years ago, 15 years ago. And the fact that she also, it's notable that she's already had a side effect of pembo, and again raises concerns, as Robbie was mentioned, is that they can get itises of anywhere. So are we just seeing another itis related to this? I love the fact that you asked about doxy, about potassium. So thinking about esophagitis and like common things being common, like piloesophagitis can happen, and just to make sure that that doesn't get buried in a presentation of someone who has underlying malignancy on a PD-1 inhibitor as well. So kind of walking through the exam, part of the reasons I was just like wanting to know how old is the patient, to kind of put in context those vital signs. Someone's a 61-year-old with a malignant cancer. What I'm trying to figure out is that like 90s/60s, is that her baseline, or is that she's a bit more hypertensive than, and that's when I would like probably try to get take a look at her other blood pressures to get a sense of like, is this normal for her or not? She's like a little bit more tachycardic. And with all that is going on in her mouth, you have the breakdown of the barrier. If she has caries, it's mucositis alone by itself, but it can also be a portal of entry for bacterial infections. So kind of thinking about, is she more like septic, is like sicker than I thought as well. And in terms of like the plaque on the soft palate, like, in someone who has underlying malignancy, and I mentioned like Candida is the one that comes to mind as well. And if with all like the redness that Kanu and told us about, again, thinking about mucositis, the other thing to think about, like just because there is something going on in the oropharyngeal esophagus is still on the play. So we can't, just because we see this, we don't see the esophagus. So I'm still thinking about like esophageal causes as well. RG, what do you have to add?
Nada. Absolutely superb. All right.
So the labs. So I'll start with the very initial labs. White count was 15,000. 58% neutro, 20% lymphocytes. Hemoglobin was 15. Platelet count was 338. Sodium was 139, potassium 3.9, bicarb 12, an iron gap of 29, B1 of 15, creatinine of 2.9, baseline was 0.9 5 days earlier. Blood glucose was 84, a lactate of 2.4, and beta hydroxybutyrate level was 49. TSH was 3.09, LFTs were normal. And we also got a UA, which obviously revealed ketonuria, but no blood or protein, and no cast either.
Amazing, Connor. Thank you for presenting ER style. This is the whole point of 30-minute VMR. Maybe I'll just, for the audience, summarize what I grabbed as the pertinent data, and please feel free to correct it. So we see a neutrophilic predominant leukocytosis, acute kidney injury, and evidence of ketosis without hyperglycemia. Is that fair? Is that anything else that jumped out to you?
No.
Okay. All right, y'all. A story. Okay. I would lose every single, oh man, I forget the name. I mean, there's a name for it. Remember when, I don't know, I'm assuming you had a similar childhood than I, that you'd have these like races where you'd have to carry an egg with a spoon and hold, what is that? What's that called? Help me out, people.
I think I grew up here.
I didn't either. Yeah.
I don't know.
I don't know. Okay. So maybe it's a Lebanese thing. Yes. Thank you, Maria, for an excellent summary. It's called the race with egg on spoon. Yes. So I remember as a kid, we would have very ridiculous things like that, where we would race and try to, like, you know, it'd be like a 3-minute stroll, but you'd have to get to the finish line and make sure that the egg is balanced on the spoon. Now, you may wonder one of two things. Am I crazy? Which is a very fair question to bring this up now, but I promise you it has a lot of relevance. The only way you can make it to the finish line with the egg balanced on the spoon is if you are very attentive to the center of gravity of the egg. You need to have the spoon right there at a very strategic spot, balancing the egg so it doesn't fall. And instead of trying to catch the egg constantly, if you focus on trying to figure out where does the egg smoothly balance, what is its center of gravity, you're done. That is one of the most important points in clinical reasoning, is knowing what the center of gravity of a case is, which means what is the sum total of all the different parts and where do they lie? And the key analysis of the labs comes with realizing the following fact. Is this a systemic disease with predominant mucosal manifestations? Or is this a disease whose center of gravity lives in the oral mucosa? Now that changes everything. If this is a systemic disease with prominent mucositis, then you have to think about diseases that have a predilection for the mucosa but involve the whole body. It's very different to saying that the entire disease lives in the oral mucosa or maybe the esophageal mucosa. And the problem is the labs are actually a little bit tricky to make that determination. I'm not shocked that there's neutrophilia here. There's profound inflammation in the mouth. And the question is, are the ketosis and acute kidney injury simply a consequence of the fact that the patient can't eat or drink? Or are they a clue to the presence of another cause? Now, there are only really 3 causes of ketosis. There's diabetic ketoacidosis, alcoholic ketoacidosis, and starvation. And there's no reason to suspect alcohol use here based on history or the labs. And there's no hyperglycemia to suggest DKA, though if the patient were on a SGLT2 inhibitor or on glucose-lowering therapy, you would still suspect that. So we go back to the hypothesis that this is starvation ketosis. But what about the acute kidney injury? Does the patient have this degree of acute kidney injury from not eating or drinking? Possibly her blood pressure is low. But may she have, is the oral mucosa the same reason? Is the disease in the oral mucosa affecting the kidney mucosa? And that's where the possibility of multiple effects of immunotherapy comes to take life. Could she have the following hypothesis? Could she have immunotherapy-related mucositis and immunotherapy-related interstitial nephritis, resulting in spillage of ketones, ketonuria, and and acute interstitial nephritis. What catches my eye and further supports the notion that she might have acute interstitial nephritis is her potassium. The fact that her potassium isn't higher than it is, the fact that it's normal in the face of the plummeting of her glomerular filtration rate raises the possibility that she might have, along with her interstitial nephritis, a renal tubular acidosis. What would further support that hypothesis is if we look closely at the urinalysis and see whether she also has difficulty concentrating her urine, which would be another support of an interstitial nephritis. And that would be, if in this case, her specific gravity is anything but super high, that case for interstitial nephritis might be augmented. So that's the tension is this case. Will we drop the egg or will we catch it? And the key part is knowing what is the center of gravity. And right now, you could easily say, this is all pre-renal, let's give her fluids and the kidney goes away. Or you could say, wait, hold on. Could she have immunotherapy, mucositis, and nephritis? And the K, the ketones, and the specific gravity might help push you to the more morbid hypothesis. All right, Kanu, I'll give it back to you for Charmaine to take us home afterwards.
Yeah, well, that was a great reflection. I was thinking about the renal tubular acidosis, but I didn't link the nephritis part. And I think we deferred it to the outpatient because she was really sick at that time and she was not stable enough to get a biopsy done. To complete the rest of the workup for odynophagia, the autoimmune workup for ANA, C-ANCA, P-ANCA was negative. A KH mount was also done, which is negative for any fungal elements. She tested negative for syphilis, HSV, IgM and IgG, CMV, IgG and IgM and PCR. Mycoplasma antibodies were normal as well. EBV, IgG was more than 600, but IgM was 46.4, which is indeterminate. CT of the neck with contrast was done, which shows some tonsillitis without any abscess and pharyngitis without any abscess also. We proceeded with the laryngoscopy first, followed by upper GI endoscopy, which definitely showed some erosions and ulcerations with crusting in the oropharynx and mild erosion in the back of the tongue, but no ulcers or anything noted in the esophagus. That's where I ended, and then I'll reveal the diagnosis.
Thank you so much, Kanu. This is a fantastic case. Thank you so much for presenting it. And I think we all have PD-1 and PD-1 inhibitor being the culprit in the back of our minds, but as a kind of beautifully done here to think about like all the infectious etiologies that could also cause it is quite important. And the other thing that I just kind of want to point out is like keep that adrenal insufficiency as you're taking care of a patient like this in mind, especially as people get sicker. You might need to increase the steroid dose that they get. So a lot of the times what happens, like patient come in, they get sicker. So just keep that in mind and increase that steroid dose as well. In terms of this, I am the most worried about the PD-1 induced mucositis, and again, like vigilance with making sure there's not a bacterial or any infectious complications of that, and usually just kind of supportive therapy would be kind of like how, and with close monitoring would be how I would do this. RG, what are your additional thoughts?
Nada, as per usual. I don't have any thoughts about the case, but I'm just so
oh no, I knew there was some brilliant thought that was going to come. And RG, can you hear us?
Yeah, I think I froze for a second.
Yeah, you froze as you were just going to say something very brilliant.
Yeah, so thank you. In fact, this is the one time where I will agree with you that brilliance is coming your way, which is anytime that we have an intern presenting a case to us, I'm in awe of that. I just remember intern year and never being able to rise above water. So the fact that Kanu is here and the fact that he's taking time out of intern year to flex his clinical reasoning skills is unreal to me. It's out of this world. But then look at this presentation. In 25 minutes, we started late. You're able to paint a narrative and share a story like this, which As you will remember from joining us on VMR over a year ago now, was probably much harder to do then. And so it's amazing, your growth and your knowledge structure and your ability to tell these stories is literally captured on tape. So I hope you'll take some time, and either now, probably not now, but maybe when you're less busy, to just literally watch yourself become the physician you always wanted to be. It's we all see it happening, and it's a treat. Yes, I'm trying to get some brownie points so that even if the answer isn't pembrolizumab, that you'll just wink at us and pretend it is. But I'll give them.
It is pembrolizumab induced mucositis, and we discussed with the oncologist. And because patient had so much autoimmune phenomenon before, including adrenal insufficiency, hypothyroidism, we suspected it should be that. So we gave her high dose pulse steroids, and the patient actually improved within a span of 2 days. She was able to start to swallow liquids, and then gradually over the next 7 days, she was able to even take solid diet. And her confusion actually resolved within 2 days of getting the steroids. So I was really happy that this case turned out really well.
With a doctor like you, Kanu? Absolutely. That was awesome. Thank you so much for presenting this case. I'm glad she did better after that. You know, cancer sucks, and I'm glad we have therapies for it, but there are a lot of complications and a lot of suffering that goes with that. So I am grateful that this patient recovered, and I'm grateful for physicians like you. And RG did have very brilliant points to make. I'm gonna leave that be. Sammy, we're ready for you.
Yeah, thank you for this amazing case, Kanu. I learned a lot, and amazing discussion by Ravi and Charmine, and also the chat was on fire, so I really enjoyed it. So let's go to the teaching points. When we approach dysphagia, we always have to think about oropharyngeal versus esophageal, and also is it motility related or obstruction related, and it's important to remember that the obstruction can be internal versus external process. For example, an internal mass or external compression because of cervical spine problems, for example. Then we are looking for clues. Is it with solid or with liquids? What's the timing of the impaction? Happens it soon after swallowing or some seconds later? Is there associated drooling, coughing? Where's the location? We can also ask the patient, where do you feel that the impaction is located? Accompanying symptoms. Also, it's important to remember medications that used to get stuck in the esophagus, like iron tetracyclines or bisphosphonates are the most common culprits. Then we thought about odynophagia in the setting of dysphagia, and Ravi taught us that it's important to prioritize an inflammatory process because of the odynophagia, and that we should consider infectious versus non-infectious etiologies, and that it also prioritizes an esophageal cause of the dysphagia. And infections that like to infect the esophagus are usually Candida, HSV, and CMV, and it's very important to remember that they are associated with immunodeficiency states, for example, HIV. Then we talked about cancer and its complications, and there are usually 3 effects which cancer can lead to complications. First is mass-related, direct effect. Second would be paraneoplastic, for example, seen in SIADH or paraneoplastic thrombosis. And third is treatment-related, what is mostly a little bit underappreciated. And this was also the case here. When we think about immune checkpoint inhibitors, basically it is everything. Every organ can get inflamed by immune checkpoint inhibitors, mostly the endocrine organs, the pancreas, the hypopituitary gland, the thyroid gland. When we see plaques in the mouth, it's important to think of it maybe as the tip of the iceberg, and that also the esophagus and maybe a more systemic process could be involved. And we should also always screen for HIV in these cases. Ravi also taught us that it's important to focus on the center of gravity in the case and not be dismissed by the noise that usually happens in clinics, and also in this case. That's an important principle in clinical reasoning. Is it local process or more a systemic disease? When we see ketosis and ketonuria, there are usually 3 causes of it: diabetic ketoacidosis, alcoholic ketoacidosis, and starvation. And rarely you can also think about SGLT2 inhibitors. Then we had the interesting constellation of AKI, low potassium, and ketonuria in a patient taking immune checkpoint inhibitors. And yeah, it's important to consider interstitial nephritis with electrolyte wasting and ketone wasting through the nephron, and also RDAs, which are usually associated with a non-anion gap metabolic acidosis. And the last point I want to make is that it's important to increase the steroid dose in acute stress situations in patients who are deficient of it in primary adrenal insufficiency. So thank you so much for participating. It was a lot of fun, and have a great day.
Robbie, I think Sammy just elevated our discussion with that teaching point. Oh, you are brilliant, friends. Kanu, Sammy, thank you so much. Gabrielle, thank you so much for scribing too. Archie, always a pleasure. Thank you all for joining us. This is always a highlight of the week for me. See you tomorrow.